Hi everybody, my name is Stuart Schlossman and this is an MS Views Now program, and this is sponsored by MS Views and News. And what we decided to do, something really crazy, strange and different, all in one saying, okay, is that I flew up here today after a major rainstorm, okay, and it's stuck in the airports for a long time. But the idea is that we wanted to come and we wanted to show people what it may appear like to be visiting with an MS center, all right? And yes, we are located at the Andrew C. Carlos MS Institute. This is at the Shepherd Center, okay? And that's because Dr. Ben Thrower gave us permission to come in here and do this program so we could just show you bits and pieces about the center. So going along, we have a patient here, Kristine, okay? We came to visit Kristine, and and you can move on along, right? So we're here with Kristine, and I wanted to ask Kristine, what is it that made you to decide, or what made you decide to come to an MS center?
So my journey may not be that much different than some of you listening and watching, or it may be very different. But I started out, having issues and symptoms, and I saw a local neurologist for several years, and I couldn't get an answer as to what my diagnosis was. And so after years of testing and visits, I was referred here for an appointment at the MS Institute at Shepherd Center, and my very first appointment was with Dr. Thrower, where I received my diagnosis almost 11 years ago.
Wow. Okay, great. And I know you moved away, which is part of this whole reason of why we're here. All right, it's to show people that you don't have to live near an MS center to go to an MS center. You can live far away. I mean, you live 50 minutes away, but there are people that live 4 hours away, and we'll discuss that again afterwards. But I just wanted to let people know that you could be living far away from an MS center, and it's great that you've seen the neurologist that you've seen, but occasionally, once a year or once every 2 years, you should come see a doctor at an MS center, yes? Okay, great. And it's not just that it's an MS center, it's a comprehensive MS center, correct?
That's correct.
Okay, so what did you want to ask me to do with you today?
So, I actually have an appointment with Dr. Ben Thrower.
That's
and
awesome.
Would you like to
Absolutely.
come back with me?
Let's go take a walk.
All right.
So, while I'm walking, I want to let everybody know that we're going to be doing this for about 45 minutes. We're going to be with Kristine, we're going to be with Dr. Thrower, and then after the 45 minutes of learning about this MS Center and the things that they have here, we're going to be doing a Q&A as well. So you could ask the doctor or Kristine questions that you may have, all right? And it doesn't have to only be about the center. If you have anything to ask about multiple sclerosis, you can ask Dr. Thrower as well, okay? All right, so next, what are we doing now?
Well, I'm here for my appointment.
Very good. Welcome, Kristine.
Hi,
good to see you.
good to see you.
Thank you for nice seeing you as well. Thank you very much
for
for inviting us here. I was telling everybody that you asked us to come in and so we can show people what it's like to go to an MS center and learn about the different things that you have. So why don't you take it away? I know that you wanted to speak with Kristine about how she's doing.
Yeah, so just first kind of a little overview of kind of what we do here at Shepherd in the MS Institute. And I would say that what we do here is we see at MS centers across the country. What we hope to give your audience a kind of a feel for is what they could expect to see if they went into a typical MS center. Of course, we like to think that we do a great job, but there are plenty of great centers around the United States. So the Andrew C. Carlos MS Institute was founded back in 1991. We take care of about 3,000 individuals with MS. We have about 14,300 visits with the community that we serve. And we really look at ourselves as a community resource. Kristine's going to be able to speak to her experience here. And we want people to use the comprehensive services here in whatever way fits them best. But we wanted to give your audience really a sense of what it's like. So a person comes into the waiting room where you guys started at, you come into the exam room, what are some of the things that you might experience, and then we'll kind of take it from there.
That's great, but I doubt people are going to go into a waiting room anywhere and find me walking in to see them.
or me.
Right, exactly. It's not the doctor. You're going to find somebody else that's going to come out to the waiting room to take you inside. So why don't you come on inside, and I'm going to stand on the side, and I'm just going to ask questions as you speak with Kristine.
Wonderful.
Okay? Great.
So, Kristine, you're a pro at this. You've been working with us here at Shepherd for a while, and you know, one of the things that we try to do is make this a one-stop shop. So, you know, so many of the things that people with MS experience, MRIs, infusions, you know, the therapy services, we'll talk about some of those things. So frequently, by the time you would get into the exam room, you know this, you may have had an MRI upstairs. I'm old enough to remember the actual film days. So, you know, you were upstairs getting your MRI, they were printing the films off, someone ran them down physically to us. Well, those days are over now, everything's digitalized. So while you're getting ready upstairs, those films have already been sent down to us. We've reviewed them here. We can show them to the individual with MS if they'd like to take a look at their MRIs. Typically, before you get back here, you're well aware that the nurses or the medical assistants have done some things outside of the exam room. A lot of the things we do in MS now is about collecting outcomes. We want to know that you're getting the very best care possible, and we want to measure that objectively. So one of the things we might do is a timed 25-foot walk. We may have you do that 9-hole peg test. We may torture you with the cognitive test. We used to do PACE-App, which was a really bad one, and now we've moved on to the other test where we actually just have you match symbols to digits, the symbol digit modality test. A little kinder for you. So, I mean, from your standpoint, you know, is it important for people with MS to have kind of one-stop shopping as they kind of put all of these pieces of the puzzle together?
Yeah, I mean, the benefits that, for me, that I've personally seen, especially when I was first diagnosed about 11 years ago, was when it came time for me needing all the different services. What was really important, and I know you talk about this a lot, is it's patient-centric care here. And so, you know, I was at the center, and I have this team surrounding me. If, you know, I needed OT, I needed PT, I needed a speech therapist. I had, you know, I have swallowing issues, so we needed a swallow study. That happened here. At one point, I needed a dietitian. That happened here. I also, you know, participated in some, you know, wellness classes here. So it's all here. And also, what really is important is the relationship that we have and our shared decision making together with my care and my treatment.
Yeah, I think that's so important. So one of the things we always tell our folks that we work with is that our team here looks at ourselves as being kind of your guidance counselors. We want you to know everything we know so that we can then make a shared decision together. And ultimately, you're the captain. So you're making that final decision. Back in the day when we only had interferon therapies or glutaric acetate, you know, sadly, a lot of people in the healthcare profession were guilty of what we used to call 4 kits and out, giving people 4 kits of information to look at and letting them have to sort through the data and make a decision, which I think is really an abdication of our responsibility as healthcare providers. We're very proud of a lot of the therapy services that we offer here, and one of the things that I think we're trying to get the message out on is something called integrated therapy program. So our integrated therapy program is a day program, but we also lovingly call it boot camp. So it's very aggressive rehabilitation. Back in the day, 20, 30 years ago, if someone had a lot of rehab needs in MS, we could just put them into the inpatient setting. No insurance carrier is going to do that nowadays, going from outpatient to inpatient. So the integrated therapy program here is a 3-week program trying to take all the benefits that someone would get in that inpatient setting and recreate it in an outpatient setting for people. Yeah. So You work a lot with people in the MS community. You've worn a lot of different hats other than just a person living with MS, and you're very appreciated. What are some of the challenges that you see for people who are living in outlying areas, or challenges or misconceptions that you see for people working with a place like this?
So just I think people reaching a diagnosis and then finding a community neurologist, I think, is in rural areas, people that are knowledgeable about MS. So even if they do find a neurologist, their knowledge about MS may be limited. And then the way that, when I've talked to some people, the way that they go about treating their MS. So some community neurologists may be doing kind of the first line therapy method instead of just, hitting it hard with some of our more aggressive therapies. So there's, variables. And I think Stuart mentioned this earlier, is some people think, oh, I live an hour, 2 hours, 4 hours away. But I have friends that live in other states that, come here once a year or, twice a year, and they actually coordinate their care here with, you or one of the other doctors, and then see a neurologist back home. So it can work a few different ways with an MS center, even if you don't live close. And you can go and get a second opinion at an MS center. You can, use the MS center as somebody to help coordinate your care. If you have a neurologist near where you live that you like and you want to keep, and that's okay too.
Great. So why don't we see if Stuart has some questions or thoughts here?
So that's great. I first off, I love your dialogue. I love your answers. It's like, why do you need me here? I mean, let me just step out of the room, all right? But I want to ask some things about this center, all right? So you have your FDA-approved medications. Do you have a specific way that you know how or which patients deserve to get what?
So that's a great question, and there are really almost two paradigms out there. Most MS centers like us, I think what you will find is we tend to be on the more aggressive side with treatment. We would rather offer people a more effective therapy if they look at the risk-benefit ratio and decide that that's not the right choice for them. I can live with that, but I want them to at least know that there are differences in the effectiveness across different therapies. Because of that, we do end up using a lot of the more effective therapies. Some of those are infusions, right. And so we do a lot of things like ocrelizumab and natalizumab just because we think that we can manage the safety of those medications and still offer people a very, very effective therapy.
Right, thank you for that. All right, when it comes to things that are happening to you that are not specifically neurologic, you have a bladder problem, you have cognitive problems. Do you see the clinician in your area, or would you rather it all be tied in together to the MS Center and see somebody from the MS Center?
So that's an interesting question. So because
I asked.
Yeah, so because I've been dealing with this, for about 11 years, I'm a little more versed in this than I was in the beginning, but I still trip up sometimes. And so, with the bladder issue, it gets interesting because we can get urinary tract infections. So the first thing I ask myself is this a urinary tract infection? Do I feel like it is? And if so, I need to get tested for that. And that's not, this place is not an appropriate place to come and ask for an appointment to get tested for that. So that would be like my primary care doctor. Right. If it's more of like I'm having some incontinence or, I'm having to go a lot or things of that nature, that's a symptom, a new symptom that I would bring up here in discussions. Cognitively, yes, I'm not afraid to say I've had a neuropsychological evaluation done here, and those reports and results were discussed with the neuropsychologist here and Dr. Thrower. And I, yes, would rather that be here with the team here.
Okay, thank you for that. Now going a step further, so if she were seeing doctors on the outside, how does the center here collaborate with those doctors on the outside so that way you all know what's going on with her as well?
In a perfect world, those outside healthcare providers would be part of the same electronic medical record that we're part
perfect
of.
world.
So maybe they're on Epic, which is the system we use. Sadly, not everyone is on the same EMR, but if they're on the Epic system, that makes life a lot easier. We can see their records in real time. If not, then we have nurses and case managers and the individuals with MS themselves tracking those records down and getting sent to us. Sadly, still, for all of the high-tech things that we do in healthcare these days, one of the weak links is getting a piece of paper from point A to point B and making sure that the healthcare providers at both ends are seeing that report or lab value. So it is vitally important, because if we're going to be truly comprehensive meaning we've got all the pieces of the puzzle to do a great job. The flip side to comprehensive is integrated. Integrated means all those pieces of the puzzle are talking to one another. We want to be integrated within our own system, within the walls of our MS center, but we also want to be integrated with all these other healthcare providers out in the community so that we're all on the same page.
Yeah. So what do you do though with the places though that are not on the same system? I mean, I have that problem. It's horrendous.
It's old school. It's getting pieces of reports, sent in and put in a folder on my desk and making sure that I see those.
Right.
And part of that I feel is also on me. So like my neuro-ophthalmologist, who's wonderful, and I see him, I always say to him, hey, you're going to send your notes over to Dr. Thrower, right? And I know he does. I also see a nephrologist, a kidney doctor, and I say, hey, you're going to send those to Dr. Thrower, aren't you? And I make sure they do. And if they don't, I follow up. And so, a lot of this is on us as well, to kind of, herd the cats, if you will.
Yeah.
Right. I know I went to my primary a couple of weeks ago, and they're like, we can't find any of your medications that you're on. I said, I was here a year ago. And they said, well, we can't find it, so you have to come up with the list again. I said, you're connected with electronic records, aren't you? What are you talking about? We're only connected to our system. And I said, well, what's the whole purpose of the electronic records? I mean,
it is frustrating that people are spending millions of dollars on these EMRs, but unless they're on the same EMR, those EMRs don't talk to each other.
I'm connected with two other large hospital systems that do communicate with each other, but this one does not. So it's like, well, while you're doing whatever, do your own thing. Let me get into my phone and find out what my medications are.
Yeah.
But yeah, that is a challenge for people. So going into something else, let's talk about what you do here for research. I'm sorry that I'm going to cut away from you for a minute. What do you do here for research opportunities?
So research here is actually its own standalone department, which I think is the way things should be. So we're not asking our clinic nurses to serve as research coordinators. Being a clinical research coordinator is a huge job. The amount of paperwork and detail that these coordinators have to manage is truly monumental. So research is its own department. So when we look at clinical trials, we put ourselves in the position of the person with MS or their family. We want to pick trials that can have the person with MS and minimize risk. We probably turn away 75% of clinical studies on a monthly basis because they're not fit for the way we manage MS. Maybe there's a placebo group in a relapsing remitting MS population. If I'm a person who's living with relapsing remitting MS, I don't want to be in a placebo controlled trial. We have treatments available. There's a risk associated with that. So we're very selective in what trials we do. Most of our studies would be phase 3 clinical studies that are probably being designed by a pharmaceutical company. We are doing phase 1 and phase 2 trials. We're part of a large mesenchymal stem cell study. And then a lot of the research that our rehab folks are doing would be investigator initiated. So there's obviously no pharmaceutical company, designing a rehab-based trial. So these are researchers in the rehab world who are coming up with their own designs. We're doing a lot of research on things like functional electrical stimulation bicycles to improve endurance of people with MS.
Sure. So I just want to tell the people at home, so there are people that came on late, all right? We're not here actually to promote this one MS center. We're just here to discuss what can be found at an MS center. And each MS center is actually different. So you're going to see a lot of things here or hear a lot of things about what's here today that may not be at an MS center that you either go to or know of that's near you, and that's not taking anything away from anybody else. It's just that we happen to be here, okay? So I just want to go forward with that. All right, and again, we're here with Dr. Thrower, in case you didn't check in early enough, and we have Kristine here as well. I'm not going to say her last name because she didn't allow me to say her last name, so I'm not joking, but I didn't even ask. So, but Kristine is an MS patient, and we're here, and Kristine's talking to you from her perspective of what she finds useful about being at this MS center. All right, so going forward, let's see, what do we have? We have that, I wanted to know from you, you were talking about the different therapies. Can you give a listing of, the different treatments that a person can have by coming to this specific center?
Sure. So putting the medications aside, just focusing on
Sure.
kind of ancillary services, the therapies. So physical therapy, occupational therapy, huge role in MS. And again, the both of these therapists are contributing quite a bit to our integrated therapy program, that 3-week boot camp. Speech language pathologists, I think, are one of the most interesting groups in the MS world because they probably wear the most hats. So they do traditional swallowing issues, they do word finding difficulty, but they also work with cognition in MS. So they can do cognitive rehabilitation. We keep them pretty busy. Neuropsychologists that Kristine mentioned. Neuropsychologists are frequently working side by side with the speech language pathologists in that cognitive realm. We usually think about doing full-scale neuropsychological testing if there is a vocational issue. Someone's thinking about modifying their work or leaving the workforce, and we really want to shore that up. We sometimes do it in other settings, but that would probably be the most common setting. We have vocational rehabilitation specialists here that would work with your employer to help you kind of come up with accommodations that might be appropriate. One of the modalities that I'm especially proud of here is our seating clinic. So if you need a manual wheelchair, you're thinking about an electric scooter, you need power mobility, what we would not like to do is just send you directly to the vendor. For instance, if I send you to a store that only sells electric scooters, well, you're going to get an electric scooter because that's what they sell there. I want a middleman, a physical therapist who's going to evaluate your specific needs, come up with a prescription that's appropriate for you, and then advocate with your insurance company and with that vendor and make sure you get what you need. A power wheelchair could be $25,000, and typically when you get one, Medicare doesn't want to change that out for 5 years. We want to make sure we get it right. We do a lot of driving evaluations here, so if someone or their friends or family are expressing any concerns about safety of driving and we're thinking about making adaptations, maybe hand controls, or someone just wants to know, hey, I feel like I'm missing the red light. Am I safe to drive? We're going to give them an honest opinion on whether that's the case or not.
That's fabulous. What about a person using a cane? There are different heights for different people, aren't there?
Absolutely. So anytime we start thinking about some kind of assistive device for walking, whether it's a cane, a walker, a brace, I would rather the person with MS not just go to the store and buy something. Like you said, there are different sizes. There are appropriate and inappropriate ways to use a cane. You can actually put yourself at higher fall risk by using a piece of assistive technology inappropriately.
Okay, thank you for that. And for everybody online that sees me using a piece of paper, I'm sorry for that. But I had an exhausting ordeal trying to even get here today, and I didn't get a chance to read my notes, so sorry. Okay, going forward, let's talk about services. Okay, you ready to talk about your services?
Absolutely.
What services does the MS Institute at Shepherd Center provide, and how might this compare with other MS centers?
So I think we've covered some of the rehab services and the research services. Some of the other, I think, vitally important pieces of the puzzle, service-wise, that we offer is case management. How do people navigate insurance plans if they need home health services? I cannot imagine my healthcare team doing what we do without the case managers that we have. They are truly some of the unsung heroes of the world, of the MS world. One of the service lines that we've just brought on board within the past 6 months is actually a bowel and bladder team, specialty team. So this was actually put together by one of our occupational therapists. She has an advanced practice provider, a physician assistant who works with her. They have urology backup. So if I'm working with someone with MS and let's say they have an overactive bladder and I've not gotten that under control with one medication, and I think their situations are a little more complicated, I'm going to refer them over to this team so that they have a whole healthcare team working with them and helping them kind of navigate those bowel and bladder symptoms.
Okay, you mentioned the physical therapy, you mentioned the physical fitness program. You did not mention anything about your aquatherapy.
Aquatic therapy, thank
There you go.
Yeah. So one of the things that Shepherd is very blessed with is a near Olympic sized swimming pool that's down on the ground floor here. It serves all of our patient population. So I work just with MS, but Shepherd also works with brain injury and spinal cord injury. We do have some interesting sort of pool temperature sort of dilemmas that come up because our MS community would like the pool to be a little on the cooler side. Some of the spinal cord injury patients want it a little on the warmer side. So we work out compromises during the summer where we have it cool on some days and warmer on other days.
But you don't play Marco Polo.
I can't say for sure they don't play Marco Polo. It'd be a great pool to play Marco Polo in.
Okay. All right. There's a few things that we haven't discussed, and I think we're going to have to go out of the room for that. One of which is your infusion room and your OCT and whatever else. So do you want to go for a stroll?
Absolutely. Let's take a walk.
Let's go for a walk.
Wonderful.
Let's all three go for a walk. After you all.
Awesome. So, because visual issues are a common thing with multiple sclerosis, one of the pieces of equipment that we wanted to bring on board here a few years ago was OCT, or optical coherence tomography. We're going to come right down here. Actually, I think they locked us out here, so it made this a little difficult.
Uh-oh, you just showed the whole world that.
That's all right. So here, this little piece of equipment sitting on the table is OCT, so optical coherence tomography. So what we can do with that is make a very detailed picture of your optic nerve, of your retina. So when we look in your eye with an ophthalmoscope, I compare that to if there was a keyhole on this door and I asked you to describe the room by looking through the keyhole. That's what an ophthalmoscope does. Imagine if I let you open the door and see the whole room all at once. That's what that does. So it makes this incredibly detailed picture of the optic nerve and the retina. It also measures your retinal nerve fiber layer. This is an area of a lot of interest in the MS world because it turns out the retinal nerve fiber layer correlates fairly well with brain volume. So as retinal nerve fiber layer volume changes or thickness changes, it does correlate with brain volume. One of the other pieces of equipment that we typically have in here that's actually charging in another room right now is the bladder scanner. So Kristine and I were talking about some of the bladder issues we see with MS, and what we would like to know in the person with MS is what's their bladder actually doing. And rather than just guessing at it based upon symptoms, we can actually do the bladder scan and measure with ultrasound how much urine is left in the bladder after the person goes to the bathroom.
Right.
And that then guides us down different care pathways. Super easy test to do, but it really is vitally important in terms of guiding us down a treatment path.
So speaking about the bladder test, what does a person have to do to have this done? Are they required to come here and drink fluids of some type and then expel, or what?
Yeah, so Kristine, you want to speak to that? I mean,
Sure.
Come on forward. Come on forward.
Sure. I actually had an appointment once and we were talking about the different issues I was having, and Dr. Thrower said, let's go ahead and do a bladder scan on you. And I was like, okay. And so the nurse came in and said, go ahead and go to the restroom, and then when you come back we'll do this. So I
Tell you to do anything in the restroom?
went to the restroom. I came back and I laid down, and it's like an ultrasound, and she had a little screen and she looked at it and did the ultrasound, and it took the video and the pictures, and then she was like, okay, I'll be right back.
Yeah, they put a machine right on your
the
bladder.
Wand.
Yeah,
just on your belly button.
Just the wand,
Right,
and then
right.
it's a handheld device, and then
All you got to do is pee and then lay there.
Yeah.
So we want you to try. We may or may not collect a urine sample, depending upon whether we suspect there's a UTI. So a lot of times it's just simply doing the bladder scan. Years ago, the Paralyzed Veterans of America came out with some really good at algorithms that tell us, well, what are we doing with that number? So the
Okay.
magic number with the bladder scan is 100 cc's of urine. You're under 100 cc's of urine, we would suspect that your bladder symptoms are more towards that small, overactive bladder end of things. Over 100 cc's of urine, we start worrying about the underactive bladder, where someone's retaining urine, puts them at higher risk for urinary tract infections.
Gotcha.
And those are two very different care paths.
Gotcha.
The ones that drive everybody crazy is, what if you get 101 MS? It's just barely over. And so sometimes we watch those and see if they declare themselves one way or the other over time.
So a person that has to pee a lot, will they be less likely then to get a UTI?
If they have a small overactive bladder, so they're emptying well, they're just doing it every 30 minutes.
Right.
Usually that person's going to have a very low value on the bladder scan. So in theory, they are at lower risk for UTIs. The person who's at higher risk for UTIs is the person who's not emptying their bladder.
Okay.
You can still have urinary urgency and frequency with an underactive bladder. So you can have a bladder that basically empties like you're pouring water in a glass and it's overflowing, but it still spasms. It just doesn't spasm enough to empty the bladder.
Sure.
So that's why we don't want to count on the symptoms that the person is reporting to definitively say, small overactive, large underactive.
Right, right. Okay, going back to the OCT, I have a quick question, and that is OCT scanning being used to diagnose an MS patient?
Not used for diagnosis yet, so it is an ancillary tool for right now. Most clinical trials in MS are adding OCT as kind of an outcome measure. I think it's going to be something that may play a role in neural repair studies. If you're losing retinal nerve fiber layer and that's a measure of brain atrophy, well, what if we did something that repairs damage and we can actually plump that retinal nerve fiber layer back up? But not a diagnostic tool at this point.
Okay, thank you for that. How about your infusion room?
Yeah, so one of the things we're very proud of is our infusion capability here, and we have a lot of people on infusion. So let's walk down and
show it to me. And by the way, while we're walking, I see all these rooms here, and I see this scale here. What is this scale about?
So this is a scale that would be used for someone in a wheelchair, either manual or power. So
Right.
that if the person is not capable of standing up and getting on a scale, we can just use this one here.
So how do you know the weight of the mobility device?
So most people with power chairs, as part of their power chair evaluation, that chair was
Okay.
weighed, and so and because they got it here, we know how much their chair weighs. So if
Gotcha.
it's a manual chair, we may have to look that one up.
Okay, got you.
Yeah.
And keep going.
Yeah.
I don't remember. Oh yeah, how many exam rooms do you have here? I
So-
mean, I know it's a lot. And this is a different MS center than others might know about, all right? But how many do you have here?
So we have 14 exam rooms. We have 24 infusion chairs here. Shepherd is in the middle of a very large capital campaign expansion. We as blessed as we feel with what we have physically right now, one of our rate limiting factors on new patients is infusion chairs.
Right.
So we really need more infusion capability here. So with our expansion, what we will do is we should double the number of infusion chairs that we have to work with. We're trying to be as efficient as possible with the infusion chairs that we've got right now, but we're bursting at the seams.
Okay, that's great. So tell us about the infusion process.
So for many patients like Kristine, who's on an IV medication, once they've been you've been seen in the exam room, we're going to start doing our orders as a physician, and we'll get them back here to the infusion room. So, Kristine, what's the experience like for you? So you come back here. Usually this is where I sign off at the exam room.
Right.
I go talk to the nurses. They come and get you, and then you kind of disappear to me.
Right.
So now you're back here. What is the experience like back here?
So usually a nurse comes and takes me back here and brings me to a chair, just like the one I'm sitting in. And she lets me know who my infusion nurse is going to be for the day. And she asks me if I would like some water, if I would like a warm blanket, which I usually always say yes to. Because at this point, I'm usually about ready to take a nap. Or I won't have a choice because some of the pre-meds I get with the infusion I'm going to get. And my vitals are taken, and then, usually wait for the drug to get sent up from the pharmacy, and they, bring it up, and then we find a vein. Some of you understand sometimes that can be a little difficult, and and then we go, and if Dr. Thur's put in orders for blood work, we'll go ahead and draw that blood and then start the party, as the nurses here like to say. Start the infusion.
So Stuart asked an interesting question earlier about, is there any prep work required to do a bladder scan? And no to that, but the infusion nurses do like you to do some homework before you come in for the infusion. So what would the nurses like for you to do before you come in for an infusion?
Drink.
Water.
Water.
Better clarify.
Right.
Yeah.
Yes, they like you to be really hydrated for a few reasons. One is so they can find a vein easily, but the second is most of our infusion meds, the side effects can really be minimalized by drinking water, especially headaches. I find that the more water I drink beforehand, the less I have to deal with any type of residual headache that day or even the day after.
So one of the things we like to do here is, as much as we can, is keep that one-stop shopping. We want to be able to do MRIs here, do the infusions here, do the labs here, do the therapy here. One of the fights that a lot of MS centers are having around the country is over something called site of service. So insurance carriers are saying, well, we hear you that you'd like to do the infusion at an MS center, but we've found an infusion center somewhere else that we think is cheaper. And so it's an ongoing battle. It is it really kind of throws a wrench into the whole concept of one-stop shopping. We're biased. We think infusion nurses at an MS center are the best. That's all they do 24/7 is multiple sclerosis, whereas in an infusion center you may be there with individuals with a lot of other health problems, and it's not quite the same. Sometimes we don't win that fight, and so we will do the best that we can to identify infusion centers that we can partner with, that we know are going to do the labs that we need to have done from a safety monitoring standpoint. But it is a challenge.
Yes, and the other thing I've really appreciated is during this time with COVID, I was also able to receive my Evusheld shots right here. Just closed the curtain. We just did them real quick, one in each hip, right before I received my infusion. We waited 20 or 30 minutes, and then we were able to start the infusion. So that was really convenient as well. And I do feel comfortable having my infusions here. If my insurance were to send me to a different infusion center, personally, I would be worried. I haven't had any severe reactions to any infusions, but a couple times when I first started one of my infusions, I had, a few reactions, and I knew the nurses knew how to take care of me.
How much of a social aspect is there back here? So a lot of times you're on a set schedule with your different infusions, so you're probably crossing paths with some of the same members of the MS community who are here on the same day. Do you see some of that back here, just a bonding social aspect?
Oh yeah, and the nurses, some of the infusion nurses I've had for almost 11 years, and a lot of the patients, I see, we're all like, oh, hey, and then even when you meet a patient you haven't met before, it's almost like you know them anyway, because we all just know. Like, why they're here, why you're here, and, you can just easily have a conversation. And sometimes you wind up making really good friends that way. And it depends on the day. Like, some days you come back in this room and it could be hopping and everyone's talking, and and then sometimes you come back here and it's like this, just dead quiet, and everybody is just asleep. Curtains are all closed, like nobody wants to talk.
It's a quiet day.
So yeah, it kind of depends.
It's interesting to me, in the times that I come back here, so there's a television on the wall behind you that on our arms.
Yeah.
I hardly ever see anyone watching television.
No.
Back here, yeah.
No, we're either sleeping, or we're talking with the infusion nurses, talking with each other, or, just in our own, cocoon, like reading or I do like Sudoku, or I'm
Yeah.
kind of nerdy, stuff like that.
So I'm going to add something to that now. And so the when I had to stop using or getting an infusion at my MS neurologist's office because their company just decided that they didn't want to do them anymore, I had to go get I'm still there at an infusion center. All right, and I was like, oh my gosh, I got to go there and I got to see all these other people that are going to be in really bad shape and it's going to be really depressing and whatnot. But actually it's not. I mean, the people are in there for whatever reason that they are there. They're just happy that they are alive to be there, and so everybody gets along. But it is very quiet, and you're right, nobody watches the TV. I mean, they're either sleeping or they're freezing because the place is always cold, okay, or they're playing on their phones and doing whatnot, right? So it's nice to go there. But it would be a lot better if I had the opportunity to get back into my my infusions with other MS patients, because right now I'm the only MS patient there.
So you're talking about the social aspect too. Is that with our wellness program? So wellness here is when someone has maybe completed physical therapy and we want to continue those, that exercise program. They can use our wellness program just like they would use a gymnasium. So
Sure.
It ranges from cheap to free depending upon the person's financial situation. One of the biggest benefits that we found with the infusion, with the wellness center, was the social aspect that people were, before the COVID pandemic, people were going there, working out, going down to the pool, doing their aquatics program, going to lunch in the cafeteria together. So there was a lot of camaraderie that we found with that. And now that things are quieting down some with COVID, we're starting to see some of that return to normalcy.
Sure. So I'm looking at some of the people that are saying things online, and some of them are asking you all to talk louder. Just simply because they can't hear you, all right? So I'm just asking if you just raise the volume up a little bit. That's what I was trying to give you hand signals about before.
I heard you say speak up, so.
Speak up, I'd say
All
that
right.
too. Okay. All right, so yeah, we're speaking up now. All right, so next, you guys spoke about the infusion process. You don't want to actually show an infusion?
She does not want me to start an IV.
Yeah.
If your doctor is starting your IV, you've got a bad infusion nurse that day.
Okay, that's great. For everybody that's watching right now, we are starting to run out of things to talk about, but I do want to let you know that if you have any questions, you can ask, okay? You can just type them in online. For those that have never been on here before, you just go up to the toolbar, and at the very top there's a red box with an arrow in it, or it's an orange box, depending on what your server sees. All right, just click on that and type in your comments or your questions. And I'm sorry that if the sound was a little bit off. I'm sorry if people heard a little bit noise in the background, and as some have said, but we are in a live environment. We're not in a stage. We're not in closed doors. This is a real building, and there are people walking around in the hallways, and we can't stop them from being what they are. So I'm sorry for that. All right, so going forward, tell me about your MRIs, your MRI center. I mean, what you do there, how you get you spoke earlier about how you get the images up quickly, but not everybody was online yet. So if you could talk about that again, that would be great.
So everything for our MS Center is on this main floor of Shepherd Center with two exceptions. One would be the wellness and rehabilitation, aquatics, and then the other would be MRI. So MRI is up on the third floor here. We have two 3T scanners. We keep them very busy. So what we would really like to do with MRIs is do them on the same day that the patient has a clinic visit. So they're not going somewhere else to get the MRIs. At Shepherd Center, the multiple sclerosis program probably accounts for 95% of the MRIs that are done. So our technicians are intimately familiar with the multiple sclerosis community. They're used to helping people with transfers. They're used to people having maybe a spasm during the scan. And we try to take a lot of the anxiety out of MRI scans. We know for some people it's not a fun experience. We tell them, if you're in the scanner and you're having a rough time, hit the button, let somebody know. We're not going to torture you. We do think we get really good quality images here with the 3T scanners. The newer generation scanners that we have are faster. Sadly, they're not any quieter. They're still pretty noisy, but they are faster. So now we have coils that we can do brain, cervical, and thoracic without actually having to pull the person out of the scanner. So we can knock them out pretty quickly.
Right.
Yep.
So what is the length of time on something like that?
So brain, cervical, thoracic, we probably could do in 40 minutes.
Wow.
Yeah, and get you out of there. And
When I go, it's 40 minutes just on the brain.
yeah, they're pretty quick.
On the 3
Yeah.
Ts. So.
And so again, so we're on something called a PACS system, which a lot of folks are. So this is a digitalized system. So literally while you're finishing your scanner up, you're coming off the table, those images are already down here. We've already looked at them, and then in the exam rooms, we can pull that up. We used to have view boxes. We used to put the films up there, but now we can actually show you the images on the computer in the exam room.
That's great. How would you compare this with centers that are still using 1.5, and why are they still using 1.5?
I mean, MRIs are expensive. So if a center or a hospital has spent $3-4 million on a 1.5 scanner, they're going to try to get as much mileage as when I started here at Shepherd 21 years ago, we had two 1.5 Tesla scanners, and they had been around we got a lot of use out of them. So the images you get on a 1.5 Tesla machine are still good images. A lot of research protocols are still written allowing 1.5 Tesla images. Your resolution, your sharpness, and your speed of image acquisition is just better with a 3T scanner. I think 3T is becoming kind of the standard now. I think as these 1.5 Tesla machines start requiring more maintenance, or you're replacing the magnets on them, at some point it just becomes cheaper to replace them altogether with a 3T.
Great. And what is going on now? A person asked about 7T.
7T is purely a research level MRI. So at some point, the higher the magnetic field, the greater the resolution of the MRI. At some point, you do worry about the safety of high magnetic fields. So right now, 7T is clearly just a research technique.
Okay, thank you for that. Sorry about my coughing too. All right, a question that I want to ask before I get into the final things is how best is time served for people who drive 4 or 5 hours away to come here to see a physician, whether it be you or any of the other disciplines of therapy, and do they get a little bit more treatment time or care time, and where do they stay if needed?
So what that comes down to is, how does that person want to use their MS Center? Are they using the MS Center maybe as just a one-time second opinion? They're being referred in just to make sure that their diagnosis is correct, their care plan is correct, and maybe they'll never come back, or they'll come back very rarely. Are they coming in to have that MS Center take over all of their care? How we design their plan is going to really vary depending upon how they want to use the resources at the MS Center. If someone's coming from a long distance, we do this for everybody, but even more so for people coming from a distance. We want to be very cognizant of trying to get as many appointments on one day as we can, so that the person's not driving back and forth. One of the reasons that we designed the integrated therapy program, the boot camp, is we didn't want people driving back and forth. So with the integrated therapy program, those patients actually stay free of charge in our residential building, which is just right across the way here. So they're beautiful apartments. If the person lives more than 30 miles away, they can stay free of charge in those apartments. They sleep, they're well rested, they come down, they work with their therapy team, and then they go right back up to their room. They're not having to drive back and forth every day. Shepherd Center does have programs with different hotels around the area. I'm sure other MS centers do this as well, where you get discounts. If someone's coming in from 4 hours and they're doing a long infusion and maybe getting an MRI, well, that's a long day. They would probably have to leave home at 3 in the morning to get here for that appointment. So maybe they just come down and spend the night ahead of time. This is where our case managers play such a big role, is in knowing those non-medical but still vitally important pieces of the person's life, so that they can help coordinate to make sure that the person gets here for those things. One of the other things that we're very blessed with here at Shepherd Center are wonderful donors in the community. So a lot of the things that we do are not paid for by traditional insurance. And so we have donors who will step up and help fund some of these, like transportation costs, or
That's great. So you can't be the only doctor here. You said you have so many patients here. So what is the size of your team?
Yeah, so just with the MS program, so we have 3 MS neurologists, so myself, Dr. Rosendahl, Dr. Loring. We have 4 APPs, so advanced practice providers, so 3 physician assistants and 1 nurse practitioner. In the MS world, generally your nurse practitioners and PAs are kind of doing the same role. What they traditionally do is they alternate appointments with us. So the physician would see the person for the initial evaluation, put the game plan in place, and then traditionally we would alternate visits back and forth. We try to leave some flex time in the APP's schedule so that if there's something urgent that comes up, we need to get the person in quickly. They'll have an appointment available for them.
Okay. Thank you for that. Kristine, I want to thank you for everything that you brought in here today. And before we get to Q&A, because there are several questions that are coming up, but Doctor, I'd like to ask you, can you tell us how this center, though, is different than other MS centers, or forget even that question. Why is it important for a patient to go to an MS center of any type, anywhere, or just see an MS designated neurologist?
So I am biased towards people with MS being seen at an MS center at least once a year, because you think about the world of neurology. So just like there have been great advances in multiple sclerosis, there have been great advances in migraine management, Parkinson's, epilepsy, you name it. And so for the community neurologists out there do a wonderful job, but it's hard to be an expert in all of those different fields. So I think people with MS serve themselves well by at least touching bases with an MS center, regardless of where you're at in the country. There are a lot of resources to help people in the MS community identify a comprehensive center in their area. The National MS Society has navigators. They can go on the consortium of MS centers website. A lot of different places where people can identify. I think talking amongst your peers is a great way of identifying good comprehensive MS centers. Go to a support group, whether it's in person or online, and say, hey, you seem to be pretty happy with your MS care. Who do you see, and what do they offer there?
That's great. Thank you for all that. Chris, I'm going to be asking some questions, and Dr. Thrower, Chris is my camera guy that's in front of me. If you've heard me say his name, I got Bill somewhere behind me, Chris in front of me. Well, you can't see Bill right now because he was hiding. But I'm going to get into some of these questions, all right? But again, I want to thank you both, all right? It was a great opportunity to get up here. I'm sorry I was late, but I couldn't help it. The weather was in the way. I'm lucky I even got here. I mean, 4 hours of sitting in the airport is ridiculous, right? All right, and my voice is going again, so we'll have to get through this in, as quickly as I can. First person is asking, what do you do for aging with MS?
So that is an area of lots of research. So how does normal human aging interact with the MS process? And we know that it does. So I wouldn't say there's an easy answer to that. It is being studied. We know that people with MS, sometimes the progression of disability that we see in MS in the person who has a stable MRI and no relapses, but they feel like their walking is getting a little worse, their cognition is getting a little worse. That probably represents the interplay between damage in the central nervous system from MS and normal aging processes. We call that normal aging, loss of neural reserve. And so that is one of the holy grails of MS. How do we stop aging? How do we keep neural reserve intact? Putting people on a more potent anti-inflammatory agent probably is not going to alter that process. So that is a challenge, but it's an area where we're seeing tremendous research. I mentioned the mesenchymal stem cell study that we're doing here. That would be just one example of a lot of different trials that are going on around the world to look at stopping that progression of disability.
Okay, thank you for that. Next question. Who qualifies for the boot camp therapy?
Yeah, so ideally you would have at least 2, preferably 3 rehab needs that we could not meet on a standard outpatient basis. So there's no set algorithm. A lot of times if I think the person is a great boot camp candidate, I'll send it over to the therapist. We'll talk about it amongst ourselves. We have team meetings on Tuesday mornings where all of the team members come together and we talk about how people are doing maybe in therapy or who might be a candidate for that boot camp program. But the general rule is at least 2 modalities, preferably 3 types of therapy needed.
Okay, thank you for that. All right, does the cervical, excuse me, I'm going to have to get water. Does the physical therapy department have a psionic neural sleeve?
Yes, we are just getting it. So the neural sleeve is the device that just got approval in October of last year for foot drop and multiple sclerosis. We've seen it. We have one. We have not put it on a lot of people yet. We're all very hopeful that it does what we think it should do. It looks like it might be a nice tool in the toolbox for helping manage foot drop. It's going to be used right along with the Bioness, the L300, which has been kind of our gold standard for a functional electrical stimulation.
Okay, great. And thanks, Bill. Bill brought me water. How about that? All right, thanks. Next question is a person writes, I had primary progressive diagnosed 26 years ago, slowly affecting one part of my body. Is it my only hope? He thinks his only hope is stem cell research. Is there anything closer than it was? Is there anything closer with the stem cell than it was 10 years ago?
So there are multiple phase 1 and phase 2 stem cell trials, and a lot of those trials are including people with primary progressive multiple sclerosis. You could argue that primary progressive MS might be the ideal candidate for a stem cell trial, because frequently these are individuals who are not on another disease-modifying therapy. So it's kind of, if you will, a straightforward situation. That's not the only modality, though. There are others. There are small molecules that are being looked at for neural repair. There's this interesting program at UC San Francisco where they're trying to repurpose FDA-approved medications to see if just by luck they might actually generate neural repair. That is potentially a very fast program, because these are drugs that are already FDA approved. You're just seeing if they might actually generate neural repair, and then we would just simply use them off-label to do that. So there are studies with things like clemistine and metformin that, if these work out in clinical trials, we don't have to wait for FDA approval. We can use those off-label as soon as we get good data to suggest they might work.
Okay, for Kristine, do you recommend to MS patients that they see an MS center anywhere, whether it be in Georgia or outside of Georgia? I know you're on social media. How do you help out with that?
So I do get asked a lot by, peers, whether they're just diagnosed or they've been diagnosed for a long time, this question. And, my first honest answer is, I want you to be happy with who you're seeing. And so if you're happy with your care and you're happy with who you're seeing, I wouldn't want you to change just because you feel like, oh, I'm not in an MS center, so I need to go to an MS center. But if you feel like, I kind of like my neurologist, but he's never brought up, physical therapy or occupational therapy or any of these services, I'm not necessarily saying that's a red flag, but sometimes what I've seen here is that we're very proactive in our approach to things like physical therapy and occupational therapy. Like when I was first diagnosed, I was having some issues, and it wasn't anything that maybe somebody could actually see, but we went ahead and like attacked those. And sometimes, it may be the other way around, where other people are more reactive, sending people to physical therapy and occupational therapy and other services. And so for that, I would say, yes. Visit one just for the services if you like the care of your neurologist.
Okay, thank you. One more question for you before I go back to Dr. Thrower. When Dr. Thrower retires, what are you going to do?
Yeah, this is a hard one. I will stay at Shepherd Center because I do love it here. And I do have a plan B, but I don't want to tell everyone my plan B because I don't want everybody else to have my plan B.
It's a great question, though, because and I would chime in and say, if we, the healthcare providers here at Shepherd Center, are doing our job appropriately, it shouldn't be about an individual physician. It should be about the system. It We have built a system that if if I retire someday, we've hired someone who we've hand selected to say they get it. They get the importance of all of these ancillary services that we offer, and so the system carries on. Yeah. Shepherd Center has been in existence since the early 1970s. A lot of our original physicians, more in brain injury and spinal cord injury, are not here. We've still been ranked in the top 10 of rehab hospitals in the United States for many years now. And as much as you like to think, well, it's the individual physicians, we're important, but it's the system that's important.
Right. But giving credit to a lot of the smaller MS centers that there are in the United States, whether they be a mom and pop shop, okay, or just running with a one neurologist and one nurse practitioner and one of this and one of that. It's very difficult, though, for, what does a patient do when their doctor decides to stop doctoring?
Yeah, hopefully that's a discussion that they have way in advance, so I was in Spokane, Washington before I came here, and so that center that I was at, Holy Family MS Center, is still in existence, and there's great health care that's offered there. So hopefully there's some sort of, every MS center out there has some sort of a succession plan,
right.
Because no healthcare provider practices forever, and you've got to have plan B. We have kind of our eye on the future, and we realize that as some of our physicians and healthcare staff get older here, we need to think about bringing that next young crop of people. We're very blessed here at Shepherd then that we partner with the fellowship program at Emory and the VA. These MS fellows rotate through here on a regular basis, so we kind of get to see some of these wonderful young trainees and kind of get a sense of, is this person going to be a fit for us? Dr. Rosenthal, who's here, that was we're very blessed that we knew from almost the first time she came over that she was going to be part of our team.
And I will say that the Shepherd culture here, just from what I've seen over the 11 years, somebody knows, I would think, working here very quickly if they're going to want to stay or not. And so I think you all do your best when you hire somebody to show them the culture, but I think they would, if they figured out, they would figure out very quickly after coming here if the culture isn't for them. So I think people either stay for a year or stay for a lifetime.
Yeah, I agree.
And I think sometimes with patients, it's the same. If very rarely is this place not a fit for a patient, and I think they kind of go their separate ways pretty fast, and then the rest of us stay for a lifetime.
Great, thank you for that. There are more and more people asking questions, but before I could even ask any more questions, there are a few people that came in late and they don't know where we are. And they want to know who you guys are, all right? So I'm just going to say again that we're at the Shepherd Center in Atlanta, Georgia, and we have Dr. Thrower and MS patient Kristine, just Kristine with a K, okay? And we'll go forward from there. All right, so we are getting back into the questions, but if you came in late, don't worry about it. This will be online within the month, okay? Because I'm very much caught up, or getting very much caught up in our publishings of our programs. So we will get this online in the month, and you will get notification that this is online. So on our YouTube channel, so you can watch this again or for your first time from the beginning. All right, next question. Doc mentioned urology department and rehab programs on the first floor of other building. Where?
So it's actually urology is on the first floor of this building. All of our rehab services are in the building next to us on the plaza level. Part of our expansion plan, this capital campaign that we're doing, is eventually the wellness and rehab services will be on the first floor of the main Shepherd building.
Okay, great. Thank you for that. Another person writes, how long is the infusion process? And I guess that will depend then on which
depends on the drug.
Right.
So yes, so natalizumab, for instance, is typically going to be faster than ocrelizumab or rituximab. And then there's a lot of just, even within the same drug, there's some individual differences. Some people can tolerate, for instance, ocrelizumab at a faster rate than other people can. So yeah, it's going to vary from person to person.
So could you specify on how long a Tysabri infusion is?
45 minutes to an hour typically, and then for the first year you're going to want to watch that individual for about 30 minutes after their infusion. They changed the labeling on that drug just within the past few months, so that if you've been on Tysabri for a year and you've done fine with your infusions, you can drop the post-infusion observation, get you out of here a little faster.
Okay, great, thank you. What can you say about the biosimilar that's coming out for Tysabri?
So biosimilars were an interesting thing. So biologic agents are not the same as regular drugs. Biologic agents are drugs that are produced in a living cell. So Tysabri is produced in a living cell. And so we don't call those generics, we call them biosimilars. Biosimilars can be a little bit different than the reference product, and that's true for all biosimilars. So like with rituximab, we have Truxima and Ruxience, which are the biosimilar versions. What the company does have to show is that the safety and efficacy is the same as the original molecule. So we'll see. I mean, what we need to know is we need to see some data on it, and then is it going to come out significantly cheaper? We know, for instance, again with Rituxan, that some of our insurance carriers will not pay for the name brand Rituxan. They'll only pay for the biosimilars because they're a whole lot cheaper. So we'll have to see where it shakes out. I'm sure Biogen's gonna has a business plan in mind.
So one of the things is what happens with those that have to be tested for their JC? Okay. That's going to throw a monkey wrench into it all.
You cannot use natalizumab without doing regular JC virus testing. So JC virus antibody index testing is your entry point to determine whether you're safe to use the drug, and it is vitally important. We would not use natalizumab if we could not do regular JC virus testing. Biogen owns that.
That's right.
So that's one of the things we have to wait and see. Is again, if it doesn't matter how great the biosimilar is, if we can't access JC virus antibody index testing, I would not use it.
Great. Thank you for that. That was my question. All right. Next question. We have, how do I get an appointment with Dr. Thrower, and what records do I bring?
If they will reach out to Whitney Blake here. I'm sorry, Whitney Craig. WHITNEY.Craig, CRAIG @shepherd.org. She's the case manager that coordinates all incoming folks, and she will take care of it for you.
Okay, great. Thank you for that. Why do I sleep so well during my infusion, a person writes.
Kristine, you want to tackle that one?
Well, it depends on which infusion I'm getting, but if it's the one where they pre-med me with Benadryl, that answers that.
Yeah.
But for me, it's I kind of joked because I just had an infusion on the 28th, and I was texting my friend, and I was like, yeah, I got a break from running around, all during Christmas. And she was like, what'd you do? I was like, oh, my break was my infusion. It's kind of like I feel like I come here and I just, everything, it's like, and you're kind of just, you can't go anywhere. And you can't do anything, and I think your body and your brain kind of know that, and so it's just this period of like rest that maybe you've needed and didn't realize you need, and so you just kind of take advantage of it.
Yeah, and we've heard people say exactly that you're taken care of. You can kind of just totally relax. The nurses are going to take great care of you, and you can just relax. And of course, the Benadryl doesn't hurt either if you're getting that as a pre-medication.
Good, thank you for that. So, it's not on here, but a few days ago somebody asked me to ask a doctor what's going on with the Solumedrol now that it's becoming better known that it's actually doing damage to your body. And this person did Lemtrada more than once, and so she and he both said that they had so many infusions and they had so much Solumedrol, and they've had it with other issues in their body. What's going on with why their hips might be hurting?
Yeah, so Solumedrol is both a blessing and a curse. It does good things. It's a great anti-inflammatory, but it does not come without healthcare costs. So it raises blood pressure, raises blood sugar, promotes premature cataracts, and causes bone thinning. And there are
people who get a really bad hip issue called aseptic necrosis of the femoral head. The top of your femur basically gets very soft and crumbly. Sometimes that's a dose-related effect, so the more steroids you've had, the more risk you are for these side effects. Sometimes even small doses. So we do try to minimize steroids if we can. So the amount of Solumedrol that you would get with some of our, as pre-medication with some of our IV meds is minimal. So whereas when you look at the individual dose of Solumedrol for a relapse, that's 1,000 milligrams per dose given for 3 to 5 days. The dose of Solumedrol that you're getting as pre-med for your IV medications is typically 100 to 125 milligrams, so a tenth of that dose, and you're typically only getting it every 6 months. So I hear exactly where that person's coming from. We do want to minimize steroids. I think the amount we give as a pre-med is the small risk is worth it.
So knowing, though, the damage that's been caused, where you were talking about in the hip joint, how does a person get treated for that?
Orthopedic surgeon, so that if you have aseptic necrosis of the femoral head, that is a orthopedic surgical issue.
Okay.
So that's different from just normal bone thinning, osteoporosis or osteopenia. That is a surgical issue.
Okay. All right. Going on to other questions here. We have 1, 2, 3, maybe 6 or 7 to go. Okay. First one. I've had MS for over 40 years. I now use a walker. Also, I've changed from relapse remitting to secondary progressive. I've had all the testing you were talking about, and my neurologist does not want to use any infusions, and I'm not sure this is good. They say PT and exercise only.
So at some point with secondary progressive MS, the inflammatory component becomes very small, and that may be where their doctor is coming from. That ultimately all of the disease-modifying therapies that we have in MS are working in some way as an anti-inflammatory agent. And with secondary progressive MS, with primary progressive MS, there's just not a lot of inflammation. Someone may be trying to say, we think the risk is more than the benefit, and that you might get more benefit from aggressive rehabilitation. Again, hopefully these neural repair strategies that are in research are going to pay dividends at some point, and that discussion would change then. But that's where their doctor is coming from with that discussion.
Okay, thank you. Next, I had remote baseline psychological exam at the beginning of COVID. How often do you recommend additional psychological testing?
So full-scale neuropsychological testing, like Kristine was talking about, you generally like to put 2 years in between full-scale testing, in part because there is a practice effect. You can improve from one testing to the next simply because you've seen that format before. More subtle testing, like the SDMT, the symbol digit modality test, just the quickie that we do here, is recommended to be done on a yearly basis.
Okay. Now, we're hearing from a patient that's from the Shepherd Center. I am a patient there at the Shepherd Center. Your listening audience may be interested to hear about the assistive technology department there for driving assessments and other services. We did mention that earlier, but if you want to bring it up again, that would be great.
Yeah, so that's a great, thank you, whoever that was. So we mentioned the driving evaluations, but assistive technologies is actually bigger than that. So if you're having trouble with your computer, running your mouse, you need some other backup system. Maybe you're having trouble sort of operating your power wheelchair, and we need to look at backup systems, things like sip and puff systems. Shepherd Center has done research with something called a tongue drive, where people who have severe mobility issues can actually operate their power wheelchair with a magnetic device that looks like a little stud piercing on their tongue. So the assistive technology here does a lot of cool stuff, and thank you for mentioning it.
Okay, great, thank you. Another patient of yours wants to know what the thoughts are on online support groups.
Kristine, I'll let you take that one on.
So I think that they can be very helpful, but personally I use caution in a few areas. One is I try to assess my own mood, because I don't want to get pulled in or pulled down by other people's moods when I'm maybe perhaps not at my best, being my best self. And the second is I use caution with the medical advice that patients tend to give on support groups. And I'm not saying it's not without good intention, but I see a lot of misinformation that's out there and being presented and given to other patients. And honestly, when I scroll through that, I get too upset, and so I just tend to stay away from them personally, because I just want to go back and fix everything I see. And Dr. Thurnes, and I can't do that. So honestly, I haven't found one that is really helpful to me, but I know people who find them really helpful, and so that's just my personal take on it. But for all of you that are listening and watching, I would say yes, if that's something you enjoy, but just use caution with the information and check the source. Always go to the source.
So let me add a little bit of that. So there are a lot of times we find people in different chat groups about MS online who really don't even have MS. They just want to be involved with something, and they get involved, but they're taking information from what they read from one marketing company or another, bad-mouthing one thing or another, or they, and it's just so people really need to try to see what their sources really are. So, okay. All right. Speaking about support groups, we have a support group leader in South Florida asking a question. Sorry, Maria. Oops, I said your name too. Hi. All right. Do neurology students go there for learning purposes to the Shepherd Center and participate in the patient-doctor conversation during the appointment?
Yes. So I'm on faculty at it's officially the Augusta University / University of Georgia Medical Partnership. I just call it the Medical School at University of Georgia because all of my students come from the Athens campus. There's the Augusta campus, but yes, that is something that I feel very strongly about. I feel that health care providers who've been around a while, like myself, owe a debt to the generation coming up behind us. Somebody trained me, somebody put up with me when I was young and didn't know too much, and now we have a duty to pay that forward to the next generation. So we love getting the students in here, and they love working with our community. One of the battles that I fight is against too much technology with the students. Some students are being trained to focus on the laptop when they're in the exam room and look at the electronic medical record. And one of my pet peeves is, your duty is to pay attention to the person in front of you when you're in that exam room. So I think we've got a great opportunity, as staff here at Shepherd Center, to work with these bright young minds and shape them into the next generation.
Okay, great. Thank you for
and
that.
I'll add that I actually, before Dr. Rosenthal came here, she was in one of my appointments with you when she was, finishing up. So I personally always say yes whenever I'm asked, not just here, but it's happened at a few other offices that I go to. If I mind that a student comes into my appointment, I always say yes, because I feel that maybe they'll have something to learn.
That's fabulous. Thank you. Just 2 questions remain. And the first one is, what is occupational therapy? I only know about PT.
So occupational therapy, think about anything you do in your day. So what we call activities of daily living. Whether you're keyboarding, you're trying to use your cell phone, you're cooking, you're gardening outside, anything that you're having trouble with in terms of activities of daily living, occupational therapists could work with. Occupational therapists may, like in our center, work with bladder issues also. Our OT heads our bladder team. They may work with energy conservation. Sometimes they share that duty with the speech-language pathology folks. So PT, tends to get does a lot of focus on ambulation, mobility issues, big joints, shoulders and hips, range of motion, strengthening, those things. Your fine finger movements are things you're going to do on a daily basis. Handwriting, those are going to be more your OT area. A lot of times we'll send people to both and let them kind of sort out where the bigger needs are at.
Okay, thank you for that. All right, people actually asked more questions, so I'm sorry to say, but we're stuck here for a little while longer. All right, first one is, Ms. Terry Walls recently came out with vibration therapy, that this is good for progressive MS.
So vibration plates, I mean, there is data out there for osteoporosis. There is a little bit of data suggesting that you might see improvements in core strengthening. I've not seen anything to make me think that vibration plates would change the underlying course of MS. Improving function is still huge, and if we can improve function with vibration plates, more power to you. So a lot of therapy, facilities where you're doing physical therapy will have vibration plates, and will incorporate those into an MS therapy program.
We used to have one upstairs.
Yeah,
the one you stand on and you hold in it.
Yep.
And it just kind of felt like, sorry, I was saying we used to have one when we were upstairs, and you stand on it and hold on to it, and it, and when you would get off of it, you could almost feel like blood flow increasing, for a little bit. But yeah.
Yeah.
We used it more for
Funny local
funnel.
story. We have north of town, up where I live, there's a store that sells very high-end exercise equipment. And one of our patients went in on probably a 3-time-a-week basis. She would go to Starbucks and buy coffee for the young guy working at and she would just go and use their vibration plate and for free and provide coffee. That's brilliant.
That's great. All right. Sorry, but I'm going to speed things up here a little bit because we have to end in a few minutes. So, are there any more studies being done on estriol? Dr. Rhonda Voshkul and hormone therapy. Can low dose this separately. All right, so let's answer that one first.
I don't know that Rhonda is doing any ongoing studies. There clearly is something there. Estriol is the estrogen that spikes during pregnancy. We know pregnancy is protective in relapsing forms of MS. Her last study showed that when she had people on estriol for 2 years, combined with glutamate, that they seemed to do better for the first year, but then it lost its treatment effect for the second year. So I don't think it's quite ready for prime time. I don't know if she's doing any ongoing studies.
Okay, and can you tell us about low dose naltrexone, or what's that?
LDN.
LDN, yes.
So naltrexone, FDA approved as an opiate receptor antagonist to get people off of opioids, sometimes used to help get people off of alcohol addiction. The reason and that's a 50 milligram tablet. The reason LDN is called LDN is because it's a fraction of that dose, typically 3 to 4.5 milligrams. There was a lot of hype years ago. The hype did not match the reality. There have been 2 that I'm aware of objective trials of LDN in progressive forms of MS. People did get a little benefit. They tended to say their quality of life was a little bit better, and when you parsed it out, it seemed to be that energy levels might be a little better, pain might be a little bit better. I'm open to, if someone wants to try it, I'm absolutely fine with trying it. I think it's a very benign treatment. I don't think the risk is minimal.
There have been a lot of people that have said that it helped them reduce fatigue.
Yeah, that's what they found in the UC San Francisco studies, is that energy levels were a little better.
Okay, back to Maria, because she asked a question. By the way, her name is Maria Zaldivar, and she's the self-help group leader, or the support group leader in South Florida of what's called the MS Amigos. But Maria is saying that, going back to what you all were saying about the support groups, that their online support group, that their people actually look forward to when they get together and have their meetings. And they also do in-person meetings, or they were, and then COVID took that away. They went online, and then they went back to, in-person and or online, I believe. So if I'm wrong, she'll beat me up anyway about this, so it doesn't matter.
Well, and I may have confused what we were talking about. So, like, actual support group like that, I think, are a different creature than what I was referring to, which are like the Facebook groups that people form that are called, like the MS People on Okervis group or something. So that's what I was referring to.
Yes.
So.
Okay, thank you for that. Thank you for that. All right, next, Maria is asking again, or saying again, that when her neurologist has students, she just loves that her neurologist allows the students to take charge and do the entire exam. So, all right. Back to the person who had asked about the special therapy that you have here. she is now saying, current patient here again, how do I access a Shepherd dietitian for wheelchair weight loss?
Just ask whoever you're seeing at your next appointment and we can refer you over. One of the challenges, and I think something she may be hitting on is when you think about the world that we live in MS, we've got all these disease-modifying therapies, and we're having to think a lot about drug selection and safety monitoring and how do we keep people on the best medication for the long haul. And then there's all the symptom management stuff that is there also. Sometimes, even though we try to allow for at least 30 minutes for a follow-up, sometimes things get just missed. And so I think, sometimes we have to get nudged as healthcare providers, to say, hey, I would really like to be referred to a dietitian because we may be so focused on the labs and the MRI and the PT that we just simply overlook it. So don't be afraid to remind us.
Right. So you're saying about who they could see here at Shepherd, but for the people that are in scooters or wheelchairs outside anywhere else, and they want to lose weight. I mean, all they're doing is they're sedentary and they're gaining weight. What do they do? Who do they see?
We got to keep them. So I think having a good dietary plan is part of it, but we got to keep them moving as best they can. So, we have exercise programs. One of the things our therapists really like doing is designing exercise programs for people who are being ignored, who have mobility issues. We don't traditionally look at that person in a power chair and say, I'm going to get you as fit as you can be. Fitness is just as important for someone in a power wheelchair as it is for someone who has no mobility issues. I'll put a shout out to the Can Do MS people. If the audience is not aware of Can Do MS, Google that, Can Do MS. They have a whole library of exercise programs for people of all levels of ability, with a heavy focus on people with mobility issues.
Right. So outside of an MS center, for people that are in rural areas or whatnot, who should they call on to help them with this?
So from an exercise standpoint, I mean, if you could be seen once at an MS center and have them design an exercise program for you, that would be an option. If that's not an option, check out Can Do MS. Again, all of the exercise programs that are on Can Do MS are free of charge, and they are all specifically designed for people with MS. There should be dietitians in really almost any community that could say, listen, you've got mobility challenges, and so your diet is going to be that much more important. I'm not a big fan of fad diets, of people doing crazy restrictive things, because you may lose weight for a period of time, but it's probably not going to be sustainable. I'm a bigger fan of sustainable lifestyle changes for people.
Sure, thank you for that. And another person writes, do you have any patients on Copaxone?
Yes, we do. Plenty. So we've got these newer therapies, infused drugs, but our original platform therapies, interferons and glutamer, still, there are people who've done very well with those therapies. I have people who've been on interferon or glutamer from day one, back in the 1990s. If it's working for you, if you're getting an A+ on your MS exam, meaning no relapse, no progression of disability, no new MRI lesions, and you're okay with that drug, there's nothing to say that you absolutely have to switch over to a newer medication.
Okay, thank you for that. All right, we're getting kudos from people. They
Very
like this a
good.
lot, and I'm glad that they liked it a lot, because I almost didn't get here.
You earned this one.
And I had to stay at an airport for a long time, and I really just wanted to leave, but I said, no, I got to be here. So
And we appreciate you.
Bill, my video guy, says, well, we could do this all virtually also, and you could be virtual. I said, it's not the same. To do something what we did today, there's just no way to do it.
Yeah.
So
thank you.
I'm glad that I was able to get here. I'm glad that you both were able to do this, and I want to thank you for that. And
Thank you.
We're just going to say that's a wrap.
All right.
Okay.
Thank you.
Thank you.
Thanks.
All right. Bye-bye.